Good evening, Dr. Varun sir.
Good
So
evening. Good evening.
we'll start the session now.
Yeah, yeah, sure. Should I start? Hello.
Yes, sir, you should. Well, this is the Cardiology Class 3 taken by Dr. Varun Pushkarna, who is the Senior Consultant in Internal Medicine, Fortis Escortis in Hospital Amritsar. Thank you.
Yeah, thank you, Sana. Welcome all the students. So we are set to do cardiomyopathy and heart failure today. I would say that these are the very important question-bearing topics in MRCP exam and in cardiology. Whenever we are done with the ischemic heart disease and hypertension and other, the next major topic is this only. So basically, cardiomyopathy is of many types, but for the sake of examination, we will be covering only few of them, and those are the major ones. Now, we will start with the most common and most commonly asked cardiomyopathy in the exams, that is DCMP. So DCMP is basically when all of the chambers are dilated. So if I would say this is the normal heart, so if I say this is the normal heart, then in case of a dilated heart, we will see thinned out LA, thinned out RA, and a thinned out ventricles. So we will see something like this. So this is an LV, and when LV should have been like this, some good thickness muscle. Here it is thinned out. So it's basically a dilated heart. By definition, all the four chambers, one, two, three, four, all of them should be in a dilated state. Not because there is a lot of volume in it, but because the muscle has given away and it has dilated. So there is dilatation of all four chambers, thinning of the muscle, and muscle means systolic function. Muscle means strength. Muscle means tone of the heart. So that is lost, leading to systolic dysfunction. One of the major reasons for heart failure with reduced ejection fraction. Etiology: idiopathic, familial, viral myocarditis, alcohol, toxins like chemotherapy, doxorubicin, peripartum cardiomyopathy. Endless is the list. And when list is endless, all you can say is idiopathic. So DCMP, usually you will never find a cause. Where you can find a cause, they are like alcoholic cardiomyopathy, peripartum cardiomyopathy, then they are named according. Sometimes even viral myocarditis can lead to a dilated heart, but usually it is the left heart which is dilated immediately after a viral disease. Sometimes one can have a all chamber dilatation. Then there is something known as Takotsubo cardiomyopathy, in which typically the heart is flask shaped left ventricle. So infundibular portion has in fact increased tone. So there is a hypertonia here, and there is hypotonia here. So the heart seems like a flask. So that is Takotsubo, usually because of extreme stress, either psychological or physical. So septic cardiomyopathy can also present like Takotsubo. Clinical features will be failure of the heart to be a good pump. So the patient will have features of heart failure. Which heart failure? Systolic heart failure. What will it show? It will show pulmonary edema. Pulmonary edema will manifest as fatigue. Pulmonary edema will manifest as breathlessness. It will manifest as cough. It will manifest as pink frothy sputum. It will manifest as lethargy. Cardiac output will be decreased, unable to meet the requirements of the body. So patient will be fatigued and lethargic all the time. Then because this heart is dilated, and so this heart is dilated, not only the left ventricle, also the atria. And atria we know have got the bundle of Kent and all the SA node to AV nodal connections. So when they are stretched, there are chances of arrhythmias, there are chances of conduction abnormalities. Then because this is a ventricle which is thinned out and it is not contracting very well, so there is some amount of blood which is there inside the cavity which will undergo stasis, and in medicine stasis will lead to clot formation. So thrombus might be formed. Thromboembolism is a problem. Sudden cardiac death because of ventricular arrhythmias can lead to sudden cardiac death. What are the investigations? How can I draw this photo? Because with time we have mastered a technique known as echocardiography. So when we do an echocardiogram, we can see the dilated chambers of the heart, thinned out muscle of the heart. that is when we call it as a dilated heart. And along with, we can calculate the ejection fraction and call it heart failure with reduced ejection fraction. Now we will discuss the heart failure in the next coming slides. For right now, it is the DCMP is one of the leading causes of heart failure with reduced ejection fraction. In ECG, because the left ventricle is stretched so much, the His bundle will also be stretched. Purkinje fibers will also be stretched. So the signal that is coming from SA node to AV node and then to His bundle and Purkinje fibers to the left side of the heart, they will reach late. And because this conduction reaches late on the left side of the heart, it leads to left bundle branch block pattern in the ECG. There can be non-specific changes in the ECG, STT changes because of the dilated. How will you manage? You cannot bring this heart back to its original location. This is dilated. But what you can do is you can reduce the preload. So diuretics, very important drug, nitrates. By decreasing the preload, these drugs, they lead to increase in the cardiac output. And by Frank Starling's principle, as the left ventricle keeps on getting filled with more and more blood, it tends to increase its contraction until a tip-off point. So when it dilates beyond that point, there are chances of stroke volume falling down drastically. So this is where it helps by decreasing the preload. Then decreasing the afterload. This is a poor heart. Imagine somebody as a rickshaw puller. So the rickshaw puller in the rickshaw puller is the dilated heart, and the passengers in the rickshaw, they are the preload, and the wind blowing in front of the rickshaw puller is the afterload. So the rickshaw puller is finding it extremely difficult to pull the rickshaw because of its muscle mass is gone now. He's thinned out. Now what you can do, you cannot make the muscle mass better all over again. So either you have to unload the passengers or you have to decrease the wind blowing from the front. So by unloading the passengers, I mean to say preload is decreased. By unloading the wind fall coming from front, I mean that I will bring down the blood pressure. So if this is the rickshaw puller, and my drawing is not very good, but then this is the rickshaw, and this is the wind flowing from front, and this is the passengers. So what you can do is you can unload these passengers, the rickshaw will move faster. You can decrease the wind blowing, the rickshaw will again move faster. Or you can put a support here that we will discuss. That is different. So heart failure management will include ACE inhibitors. We can tell the rickshaw puller to to cycle the pedals slowly. Slowly it does, more it moves without getting fatigued. So beta blockers, very important to control the heart rate. Diuretics to unload the patient. Aldosterone antagonists to unload the patient, also to strengthen the muscles a bit. If the risk of sudden cardiac death is high, we know that the risk of sudden cardiac death is because of the VTVF. So putting a patient on ICD is important. And rare and severe cases, heart transplant is the key. Then comes another type of cardiomyopathy, hypertrophic cardiomyopathy, HCM. Now, HCM can be of two types. One is obstructive, the other is non-obstructive. So not all hypertrophic cardiomyopathies are obstructive in nature. It is a congenital disorder. It is autosomal dominant, causing myocardial hypertrophy, commonly of the interventricular septum. So if this is the left ventricle and this is the muscle of the left ventricle, so this is the muscle of the septum. Now you can see the ventricular cavity could have been this big, but now it is just this big. So because of this is a muscle, it can go into crampy situation. It can just go into a spasm, and it can actually shut down the infundibulum. So when it shuts down, the aorta goes into a sudden closure and there is no blood flowing out of aorta. And this condition is known as sudden cardiac death. So leading to diastolic dysfunction and LVOT obstruction. So left ventricular outflow obstruction is there. Etiologies, genetic. So you can find mutations in the sarcomeric proteins, including beta-myosin heavy chain and troponins. Clinical features are exertional or asymptomatic syncope. Now, what is syncope? Syncope is due to no blood flowing through aorta when the heart goes into something situation like this. I'll show you. So this is the IVS, this is the LV free wall, and aorta had to take blood. So what has happened is it has gone into a spasm. So this, because this is a muscle at the end of the day, it can go into spasm if the muscle tone is high. So there is no blood flowing out of the aorta, out of the left ventricle. So this leads to a sudden cardiac death. Okay, and syncope, of course. Dyspnea, angina. Why angina? Because coronaries, they originate from the aorta, and all the coronaries, they originate from aorta just beyond the aortic valves. So that means if the blood is not flowing from aorta into the aorta, then these coronaries also remain unfilled. So angina pectoris will happen. And sudden cardiac death is also a real possibility. Echocardiography will show asymmetrical septal hypertrophy. This is asymmetrical septal hypertrophy. You see, I have drawn it in an asymmetrical manner. Systolic anterior motion of the mitral valve. So what happens is mitral valve is here. So let us say if the anterior leaflet moves in every systole, it can shut down the left ventricular outflow tract also. So same in the mitral valve. As far as the ECG is concerned, it will show LVH pattern, deep T wave inversions. So we will have something like this in the ECGs. So this is in V2 to V6, one can find such a pattern. So this is not a myocardial infarction T wave inversion. This is a T wave inversion due to hypertrophy of the muscle. So how do you treat this patient? You don't want them to go into spasm. So best drugs are beta blockers. Don't let this heart go into a spasm and lead to sudden cardiac death. So either beta blockers or calcium channel blockers for this purpose. Nitrates should be avoided. Why? Because nitrates will decrease the preload and the patient will have tachycardia. So diuretics will also do the same thing preload. So this interventricular septum is kept away from the left ventricular free wall because of the volume inside the cavity. So if I'm going to decrease this volume, then there are chances that they can this left LV cavity can go into a closure because of contraction. Septal, and how do you treat it? You put ICD for to prevent sudden cardiac death and do a septal myomectomy. So what will I do? I will just put in a alcohol ablation here. So what will it do is, so this is the aorta. Now aorta is also getting good blood. This is the mitral valve. This is also doing good. So I have released and I have increased the cavity of the left ventricle. So this is the HOCM. Then the restrictive cardiomyopathy. Are you understanding everything? The dilated and the hypertrophic cardiomyopathy, students? Yes?
Yes, sir.
Good. So now coming to restrictive cardiomyopathy. So in restrictive cardiomyopathy, the basically what has happened is this muscle, the left ventricle, instead of being elastic, it has become firm like a metal, like steel. So what will happen is it can still contract, but it cannot dilate. So if my heart had to be somewhere here, it is just placed here. It will contract and come back to this shape. That is all. So this is called restrictive cardiomyopathy. So what is the kind of failure here? Systolic is fine. So it is a diastolic dysfunction. It is a filling defect. Diastolic dysfunction will be there. So there is impaired diastolic filling due to stiffness of the myocardium. It is just like somebody has a injury in his elbow and they cannot open up their arms. Although they can, but because of the stiffness of the elbow joint, they cannot open. That is similar situation here. So etiologies are when the muscle is infiltrated by some substances like amyloid, sarcoid, and sometimes we don't find anything. Sometimes it's eosinophilic fibrotic myocarditis, or scleroderma even can lead to this. Okay. So the clinical features are right-sided heart failure because the left ventricle is not taking blood from the pulmonary circulation. So we have lungs here, we have this heart here, and this heart has to take blood from the right ventricle, right? So if the right ventricle is trying to give blood to the lungs and the lungs are giving it to LV, but LV is not taking it, the preload is getting collected here, then it will lead to pulmonary hypertension, and this pulmonary hypertension will lead to right ventricular failure. So this will lead to cor pulmonale, that is secondary to the pulmonary condition. So because usually what I've seen in restricted patients, the lung is also restrictive pattern. So right-sided heart failure, peripheral edema can happen. Uh, so whatever remains in gets collected in the abdomen. So liver will increase in size, congestive hepatomegaly will be there, pitting edema at the peripheries, pedal edema will be there. More prominent in the left-sided. And once you put in a stethoscope, you may not find much in the chest. There will not be pulmonary edema. So the chest will be clear. And because of the heart beating at a lower preload, there can be syncope and some arrhythmias. Echocardiography will show normal sized ventricles with biatrial enlargement. So atria will be enlarged. Why? Because of the continuously increasing preload. Cardiac MRI may show in amyloidosis, amyloid deposits. Classic pattern with gadolinium is there. Definitive diagnosis can be established with the help of endomyocardial biopsy, which is not available so easily. So you have to treat the underlying cause, chemotherapy for amyloidosis, steroids, all of them will help. Diuretics are important to decrease the pedal edema and excessive preload reduction. But the problem is that the cardiac output here is based on preload only. So you should avoid excessive preload reduction. Diuretics are just for symptomatic relief. The liver will go fine, ascites will decrease, pedal edema will decrease, but the cardiac output will decrease even further. So patient's fatigue will be increased. Last but not the least is arrhythmogenic right ventricular cardiomyopathy, ARVC. Very important, will come in MRCP exam every year. So basically what happens is, this is an isolated cardiomyopathy of the right ventricle. What happens is a fibrofatty replacement of the muscular tissue in the right ventricle. Now this fibrofatty tissue leads to arrhythmias. Usually it is ventricular arrhythmia, VT. So it is an literally an explosive kind of a VT storm that happens. So etiology is genetic, where desmosomal protein mutations are there. And clinical features are palpitation, syncope, sudden cardiac death, usually during exercise, and RV failure in late stages. ECG will show T wave inversions in V1 to V3 and epsilon waves. Echo MRI will show RV dilatation, wall motion abnormalities just in the RV. So patients should avoid strenuous exercise. Patients should always be on beta blockers to prevent arrhythmias, and sometimes they will require flecainide, procainamide, mexiletine, so on and so forth, amiodarone. So many drugs they need to be on. Sometimes even digoxin we start to these patients to prevent arrhythmias. And you can put a ICD for prevention of the sudden cardiac death. All right. So I would now like to have contributions from you all. So kindly you can unmute your phones so that we can have a discussion. So there is a 25-year-old male who is an athlete and collapses suddenly during a football game. He has a family history of sudden death. ECG shows deep T wave inversions in lateral leads. So what is the most likely diagnosis?
Hypertrophic
cardiomyopathy.
Very good. So this is hypertrophic cardiomyopathy. It as such is a most common cause of sudden cardiac death in young athletes, and especially with a family history of sudden cardiac death. ECG findings of deep T wave inversions in the lateral leads V2 to V6, they are highly suggestive of this thing. A 60-year-old woman presents with dyspnea and peripheral edema. Echo reveals normal ventricular size with bilateral enlargement, biatrial enlargement, and poor diastolic filling. So what do we have here? Echocardiography findings. What is the diagnosis?
restrictive
cardiomyopathy.
So what are the features that are hinting towards restrictive cardiomyopathy?
Right-sided heart failure.
Right-sided heart failure symptoms.
Okay. Features of right-sided heart failure. Fine. And is there
Normal
anything?
Biatrial.
Yes.
Biatrial
Normal
enlargement.
ventricular size, but marked biatrial enlargement on echocardiography. Okay. So that is also very important to remember the echo findings. Many times echocardiography reports show biatrial enlargement and we just tend to pass. But if you read it very carefully, they will be mentioned diastolic dysfunction grade 2, grade 3. that will be mentioned. So PA pressures will be elevated in these patients. So they will be coming. So you should always insist on asking, why did you get your echocardiography done? Was it chest pain or was it just breathlessness on exertion? So people will tell you that, okay, we got it done because the chest physician asked, because he had treated me for bronchial asthma for last 10 years. And now he feels there's something wrong with my heart. And this is what I got this echo done. And then you can say, fine, you have a pulmonary condition which is also affecting your heart. So maybe you have a sarcoidosis. So that is the time when you should start investigating for it. Although, as I told you, definitive diagnosis can only be established with the endomyocardial biopsy, but usually it's not available. So you can do these days you can do a CMR. What is CMR? Cardiac MRI. So it is very important to do cardiac MRI. Although in amyloidosis of the heart, it has a very characteristic picture, but certainly it can still show very, very importantly dysfunctional myocardium in cases of all the restrictive type cardiomyopathies. Okay. All right. So this is question 3. A 45-year-old man with a history of frequent palpitations and syncope. He is diagnosed with arrhythmogenic right ventricular cardiomyopathy. What is the definitive treatment to prevent sudden cardiac death?
ICD.
So, no matter what kind of cardiomyopathy we are dealing with, the only definitive treatment to prevent sudden cardiac death in these patients specifically is implantable cardioverter defibrillator. Why? Because most of these people, they die of
VT. Yes.
Yes, so they die of ventricular arrhythmias, and they may present with syncope. Usually they say if somebody has had a witness cardiac arrest due to a ventricotachycardia, you can put in ICD. But in these patients, you will do that even before something happens, because this is the natural history of the disease. These people, they die of sudden cardiac death. You will not wait for them to have another one or even the first episode. So to prevent a sudden cardiac death, the definitive treatment is, as you said, ICD implantation.
Okay, I have one question. Hello.
Yeah.
What is the contraindication of ICD?
So the question that you are asking is,
what is the contraindication for ICD, and what are the potential complications or hazards of implantable cardiac device?
So are you asking in context of these cardiomyopathies or generally?
Yes, in cardiomyopathy. Suppose you are planning in a patient an ICD. So before insertion of ICD and all, we should know the complications of ICD.
Yeah. So basically, when we are recommending a patient for ICD, usually these patients, they have cardiomyopathy and their ejection fractions are below 35%. And we are trying to prevent a ventricular arrhythmia. But for example, let us say these patients also have a comorbid condition, like somebody has a lung cancer, for example, a terminally ill cancer. So those patients, it is a big no. They are a absolute contraindication when the life expectancy because of some non-cardiac disease is less than a year. Then you definitely never ever put a ICD in these patients. Then other conditions are where you suspect that cardiomyopathy is not the only reason for the patient to go into ventricular arrhythmia. For example, there is a ischemic cardiac disease. You know that the patient has a coronary artery disease. You take up the patient for angiogram. You do an angiography. You find that there is a stenosis in a blood vessel. You open that up and put in a stent. So every revascularization, it decreases the incidence of SCD, sudden cardiac death, in patients of coronary artery disease. So you should actually, as a precaution, you should run a angiogram, a coronary angiogram in all of these patients. Why? Because you have to rule out ischemia in all the cardiomyopathy patients before you go in for a expensive device like an ICD. Okay. Then a patient who has an end stage heart failure. See, in end stage heart failure, I would say that what is recommended more is a ventricular assist device. Either you send this patient for a heart transplant, or you send this patient for a ventricular assist device like Impella and all. So these patients, you should always rated on the merit that whether putting this patient on ICD will give him anything. Why? Because these patients, their life becomes so miserable because of the recurrent shocks they keep getting. So they can, and their battery gets consumed so fast. So last time there was this patient who was a 80-year-old lady who was implanted an ICD in Delhi. Oh my God, she would come to me with 16 shocks in a day. And she would say, Doctor, give me something that I will die so that I don't have to bear these shocks again and again. Why? Because this is not therapy. This is not a
Right.
therapy which will improve anything. So you have to see that if there is no ischemic cardiac disease. So these are the major things. Otherwise, if I would say if there are any major contraindications, these are the ones that are usually seen and discussed. Otherwise, complications of ICD are like anything like pneumothorax, the procedure related ones.
Right.
Then it is basically we are putting in wires inside, so cardiac rupture can happen, perforation can happen, pericardial tamponade can happen, but these are all procedure related. Then there is something known as a pacemaker syndrome, but that usually happens with pacemakers only. Anything else?
Okay,
So
thank you.
yeah, and also if the patient has a aortic stenosis. So if the patient has a severe aortic stenosis, it is recommended that you open up the valve first and then do an ICU. Otherwise, if I would tell you, it is so difficult to resuscitate a patient who has had a ventricular tachycardia and aortic stenosis. No matter how much CPR you do or how many shocks you deliver to the patient, these patients, they do not survive. Why? Because the aorta is closed. So these patients, they usually fail CPR when there is a moderate to severe aortic stenosis. So these patients can also have ventricular arrhythmias, but they are not a candidate directly for ICD. First you do the aortic valve and then you do
Then
the ICD. So these are the major things that I could think of. If you have anything else that you can tell us.
and one thing in sepsis, ICD may not be a good choice. You need to treat the sepsis and then.
Obviously.
Yeah.
So this is another point that if the patient has anything which is reversible, like I told you, ischemic heart disease, so which could be triggering the reason of ventricular tachycardia. Sepsis itself can do, septic cardiomyopathy can do, septic myocarditis can do. So
Yeah.
we have to stabilize the hemodynamics first, get the patient out of sepsis. वैसे we will never do any kind of a implantable procedure in a patient who's already under sepsis.
Right.
Yeah. So shall we move to the next?
Yes, yes.
Okay. So a 40-year-old woman with a history of sarcoidosis presents with worsening dyspnea and peripheral edema. Echocardiography reveals normal ventricular size, biatrial enlargement, and severe diastolic dysfunction. So cardiac MRI shows late gadolinium enhancement on the myocardium. What is the most likely diagnosis?
Is it restrictive cardiomyopathy?
cardiomyopathy.
Restrictive cardiomyopathy.
Secondary to
Sarcoidosis.
Sarcoidosis.
so secondary to sarcoidosis, this patient, or let us say if I change this to not sarcoidosis, let us say if I write here rheumatoid arthritis, then
It will be constrictive pericarditis.
Constrictive, yes. Constrictive pericarditis.
but everything else remains the same.
Cardiac MRI shows.
Yes, so cardiac amyloidosis. From where did amyloid come? Because of chronic inflammatory state, there will be abnormal proteins which are produced, and these proteins, they will not be released by the kidney, so they will accumulate inside the body. So restrictive cardiomyopathy is the answer here. All right, very important questions coming in. A 55-year-old man presents with exertional dyspnea and fatigue. Echocardiography shows LV dilatation with an ejection fraction of just 30%. He has no history of coronary artery disease. His blood pressure is 130/85. What is the most appropriate initial treatment? Starting loop diuretics alone, initiating ACE
ACE
inhibitors
inhibitors and
and
beta
beta
API
blockers.
and beta blocker.
Refer for an
Arnie would have
ICD
been a better
implantation.
choice. Arnie. If Arnie was there, I would have gone for Arnie.
So definitely nowadays with the guidelines changing so fast, the first drug would be ARNI. Second would be if we cannot give then ACE inhibitors or ARBs. Third line would be
SGLT2 inhibitors.
so beta blockers.
blockers.
And fourth would be in this, I would say this is 1. This I would say 3, 2. This is I would say 3. This is SGLT2 blockers, and the fourth will be mineralocorticoid receptor antagonist.
Receptor.
Okay, so what we have done is we've started this patient on 1, 2, 3, 4. Now this patient continues to stay NYHA class 3. What next?
Please repeat, I couldn't hear.
So we started this patient on ARNI, ACE inhibitor, ARB, either of them. We started at good dose. Let us say Vimada 200 milligram BD. Beta blocker is now, let us say the patient is on carvedilol at 25 milligrams PD. SGLT2, let us say DAPA is at 10 milligrams once daily. And MRA, let us say Eldactone is at 50 milligrams per day. So what am I going to do now? This patient is still NYHA class 3.
Oh, still in the same ejection fraction, how much now?
So ejection fraction is again 30 to 35%.
Oh, then we have to
And the
shift to
PA
some
PA
implantation.
pressure,
I see.
PA pressure is 70 millimeters of mercury.
PA pressure is 70.
Decoction.
So the next thing I would recommend is going for loop diuretics, adding them because they were not added as of now. So I would go very aggressively to decrease the PA pressures, to decrease the preload. Sixth, I would type, because PA pressures are so high, I would like to add nitrates to this patient. And if this patient tolerates nitrates well, I can move up to a drug known as isolazine. So what is isolazine? Isolazine is basically nitrates plus hydralazine.
Right.
Okay. So I have decreased the afterload. Okay, these drugs are balanced vasodilators, ARNI, ACE inhibitor, ARB. So I have used these drugs. I have used beta blockers. SGLT2 and MRA, I use them to change the pathophysiology of the disease. Still, the patient continued to be NYHA class 3. I added loop diuretics. PA pressures came down to 45. Patient's EF remained 30 to 35. NYHA class 2. But when he has fever or exertion, he becomes NYHA class 3. What can I add now? What can I add now? So I should ask here, what is the heart rate, resting heart rate of the patient? Let us say if the resting heart rate of the patient, despite good dose of beta blocker, is more than 70 per minute, I would add a drug known as ivabradine.
Ivabradine you can add.
So it is a drug approved to be used in patients of heart failure with reduced ejection fraction when the maximum heart rate could not be achieved with the help of beta blockers. Okay. Let us say if we added ivabradine also, and the patient is patient after adding ivabradine, patient landed up into atrial fibrillation. You know, one of the complications of ivabradine is atrial fibrillation.
Atrial fibrillation.
So this patient landed up in atrial fibrillation, and I had to stop ivabradine. What next?
Diltiazem.
Can you start amiodarone?
Okay. What next? Amiodarone, fine. So
Diltiazem.
diltiazem in a patient of ejection fraction of 30 to 35%. HFrEF, you cannot use calcium channel blockers.
No.
So what will you do? Can I erase some part here so that I get some ground? So 1, 2, 3, 4 is understood. Rest everything I will leave here. Don't worry. So this patient had atrial fibrillation and the patient is on carvedilol. I stopped ivabradine. Patient still is in AFib. Heart rate remains around 100 per minute. AFib. Ivabradine I have stopped. Now what? You say amiodarone.
Yes.
I don't agree because it is nowhere in the guidelines. What next? The only other drug that you can add is digoxin. So digoxin today's only indication is heart failure with atrial fibrillation.
Right.
Only. So it has no mortality benefit, but it decreases hospitalization. So hospitalization rate is decreased with digoxin. So you will add digoxin to this patient so as to control the heart rate, and then maybe if you are lucky enough, you can admit the patient for a defibrillation, and hence with digoxin this patient should be on NOACs. NOACs is newer oral anticoagulants. So this patient should ideally be on rivaroxaban or on apixaban, okay, or dabigatran, whichever you choose is your. So this is the algorithm how you will proceed. If still this patient, okay, lands up into sinus rhythm, but after 2 years of stabilization, good stability, this patient now again becomes NYHA class 3. Now what? He has no water left in him. He's dry as a bone. His pulse rate is around 60. His BP is around 80/50. His chest is clear, but whenever he exerts, he goes into dyspnea. What you can do? So now it is a refractory heart failure.
Assist devices, sir.
Now you have to initiate a device,
Ventricular assist.
implantable
This
device.
patient needs a device. So what kind of device?
Ventricular assist device. VAD.
So this
Ventricular
patient
assist.
needs a LVAD. Okay. So let us say LVAD is a bridge therapy. So what will be the definitive therapy? Number 2.
Transplant.
Yes. So the next will be heart transplant. Very good. So everything is included. So what we have seen here is that here you would add initiate inhibitor, ACE inhibitor and beta blocker. You will add digoxin at step 8 if the patient has atrial fibrillation. Starting loop diuretics, okay, initially you will use, but then as a step 5 if the patient's PA pressures are high. ICD immediately, I don't think it makes sense. 45 days of minimum ACE inhibitor, ARBs, and good goal-directed GDMT, as we call it, goal-directed medical therapy. At least 45 days of GDMT and no improvement in clinical status or ejection fraction, then you refer the patient. So no immediately at a later date. So as you said, the answer is correct. Question number 7. A 25-year-old male athlete with no prior medical history collapses during a game. He is resuscitated successfully. Family history reveals sudden cardiac death when his father was 40 years old. Echo shows asymmetrical septal hypertrophy with an ejection fraction of 70%. What is the next best step in this patient?
Start
Implant an
beta
ICD.
blocker.
ICD.
Sir, A. Start beta blocker in restrict competitive sports.
So the thing is, patient has collapsed. So even one episode of syncope is sufficient for me to go in for an SCD, to prevent SCD. So I would go for a implantable device.
Yes,
Not, it is a recommendation. So this patient has HCM, history of cardiac arrest. His father died at 40 years of age. So there are high chances that this patient will die of sudden cardiac death. First step is ICD implantation. Second step is put the patient on beta blockers. Third step is refer the patient for septal ablation. So this is how, yeah. A 60-year woman with history of amyloidosis presents with worsening dyspnea, fatigue, peripheral edema. Echo shows thickened ventricular walls, normal chamber size, and severe diastolic dysfunction. Cardiac MRI confirms late gadolinium enhancement consistent with amyloid deposits. What is the next best step? Asking for beta blockers and diuretics, starting tafamidis, referring for heart transplant, or doing a endomyocardial biopsy.
Most likely,
Heart transplant.
heart transplant is possible in 60,
So
but the ID.
nowadays, basically TTR amyloid disease that we call amyloid cardiomyopathy. Nowadays, chemotherapy is available, which is this tafamidis, which should be started as the first line therapy. And in the meanwhile, you prepare the patient for heart transplantation because she's a 60-year-old woman, and if and she still has a normal chamber size but severe diastolic dysfunction, and gradually she will need. So the first line therapy is tafamidis. It is basically transthyretin amyloid gamma receptor inhibitor, something, and it slows the disease progression. So diuretics can be used cautiously for volume control, but beta blockers they do not tolerate. Then heart transplantation is the only. So eventually this patient will need heart transplant, but immediately you should start the patient on chemotherapy. Okay. A 35-year-old man presents with palpitations and recurrent episodes of syncope. So he's just 35. He has palpitations and recurrent syncope. ECG shows T wave inversion in V1 to V3 with an epsilon wave. So where is an epsilon wave found?
ARVD.
Yes, so it is a ARVD. So echo demonstrates right ventricular dilatation with reduced ejection fraction. What is the next best step?
ICD.
Yes,
Implant
so he had syncope. He has fallen so many times. So this is the name is this ARVC. So arrhythmogenic right ventricular cardiomyopathy. So arrhythmogenic, we have to stop we can't change the pathophysiology of the disease, but we can save him from the death. So immediate ICD implantation is important to reduce the risk of cardiac death. It is the treatment of choice for preventing sudden cardiac death. Later on, you can do ablation and all. A 45-year-old man with long-standing hypertension presents with fatigue and exertional dyspnea. Echo shows severe LV hypertrophy with non-dilated chamber and EF of 50%. What is the most appropriate treatment? Initial treatment.
Beta blockers.
So
But
beta
ACE
blockers
inhibitors.
are, yes, it is ACE inhibitors. Why ACE inhibitors? Because what it looks like is severe LV hypertrophy with non-dilated chamber. So this is likely hypertensive cardiomyopathy. So hypertensive heart disease, as we call it. So we should add ACE inhibitors to this patient to decrease the effects of hypertension on the heart. So initiating ACE inhibitors, it is hypertensive cardiomyopathy. Goal is to reduce the afterload and control the blood pressure. That's all. So because there is no LVOT obstruction, this is not an obstructive cardiomyopathy. So we will not be treating it as an HOCM. We will be treating just as a non-obstructive HCM. Is that okay? So that was cardiomyopathies for you. Now we will do heart failure. So heart failure is a clinical syndrome. It's basically a clinical syndrome. Patient comes to you with symptoms of heart failure. Not that once they are diagnosed, then they come with a diagnosis. But before that, they come just with the symptoms. So the patient has structural or functional cardiac abnormalities leading to inadequate cardiac output or elevated intracardiac pressures. Nowadays, it is classified into three types: heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, that is 41 to 49, and heart failure with preserved ejection fraction when it is more than 50%. So basically, what happens is when patient comes to you with clinical suspicion of heart failure, the first clinic test that you do is NT-proBNP or simply BNP. So once you have done BNP and its levels are more than 125 picogram per ml, that is when you refer the patient for an echocardiogram. So this is the nice guideline. This is the how the NHS works. So in the clinic, you do anti-pro-BNP. Patient has anti-pro-BNP elevated. You start the therapy for heart failure and refer the patient for echocardiography so as to label which kind of heart failure does the patient have, whether it is HFpEF, HFrEF, or HFMRF. Okay. So etiology, ischemic heart disease remains the most common cause. Hypertension, valvular heart disease, other cardiomyopathies, arrhythmias, uncontrolled atrial fibrillation will eventually lead to tachyarrhythmia associated with associated cardiomyopathy. And then toxic metabolic causes like alcohol, chemotherapy, and hemochromatosis. Clinical features are dyspnea, orthopnea, PND, fatigue, edema. Raised JVP, peripheral edema, displaced apex beat, S3 gallop, S4 gallop, and pulmonary crackles, all of them manifesting heart failure. What are the
So
blood
one
tests?
thing, what is the gold standard of heart failure?
Gold standard of heart failure means?
Means the investigation, sometimes questions come, no? That the most appropriate investigation or the best possible investigation, which is the gold standard of diagnosis
Okay. Gold standard to diagnose heart failure.
of heart failure.
Okay. So nowadays, what you have is basically echocardiography. So the most definitive test is echocardiography.
And not pro-BNP.
They are not yet gold standard.
Oh, it's echo always.
Anti-pro-BNP can be elevated in thousands of conditions. Eventually, you will come to know. But that is why to prove the diagnosis of heart failure after getting anti-pro-BNP, you need an echocardiography.
Right.
So the gold standard will remain this echocardiography, 2D echocardiography.
Oh.
Okay. So the investigations are blood tests, anti-pro-BNP or BNP, ECG may show ischemia or any ECG changes, chest X-ray may show curly B lines, pulmonary congestion, cardiomegaly. Echo is essential. See, essential. So gold standard for EF classification and cardiac MRI to label cardiomyopathies and angiography if you are suspecting coronary artery disease. How is the management? See, the patient can come to you as a CCF or a ACF. So ADHS is acute decompensated heart failure. How do you treat? You treat it with LMNOP. LMNOP is L is Lasix, M is morphine, N is nitrates, O is oxygen or NIV, and P is positioning. So you position the patient upright. Then chronic heart failure, CCF, as it was earlier known as. So you restrict the fluid salts to less than 5 grams in a day, fluids to less than 1.5 liters in a day, graded exercise, not strenuous exercise. So this is the heart lifestyle modifications. And then management of heart failure, as we've already discussed. ACE inhibitor, ARBs, beta blocker, MRA, SGLT2 inhibitors, ARNI, and then if the heart rate is more than 70 beats per minute, specifically on treatment, then ivabradine. If the patient has a frequent descent, then you will like to use isolazine, that is hydralazine plus nitrate. Diuretics are only for symptomatic relief. When the PA pressures are more than 40, you will add diuretics and try to unload the preload. Devices, ICD is indicated when the EF is less than 35% and the NYHA class breathlessness is more than 2 or 3. Transplantation is recommended for end-stage heart failure. As far as HFpEF management is concerned, the only drug approved is SGLT2 inhibitors, and there is no proven mortality-reducing therapies. You have to understand this. Controlling obesity, blood pressure, fluid overload, diabetes, hypertension, CKD, all of them are important. So this is extremely important for you. Another thing that came to my mind. So if the patient is on dialysis, if somebody is on dialysis, even if they have normal heart function, their anti-pro-BNP or BNP, both of them will be mighty elevated, 30,000, 50,000. This is their levels. Okay. Just a thought came to my mind. How to monitor regular echocardiography to assess any changes in the EF, BNP monitoring to track the disease progression. Now it is approved to follow up the patient. Assessing NYHA class and monitoring electrolytes and renal, because you are using so many drugs which can affect the renal function. So, is that clear about the heart failure? These are the basic guidelines that are important. Yeah. So now we would go for the questions to get a more better idea. A 68-year-old man with hypertension and diabetes presents with dyspnea on exertion and orthopnea. Now this patient shows bibasal crackles on examination with the raised JVP and mild ankle edema. NT-proBNP is elevated at 850 picograms. ECG shows left ventricular hypertrophy. What is your next best step?
Basic 2D.
So the next best step is to do a echocardiogram. So to label the patient, so assess the ejection fraction and structural heart abnormalities. BNP is elevated. See, so beautifully written. BNP is elevated. What is written? What is written?
Supporting.
It is just supporting heart failure.
Supporting.
Yeah, it is not diagnosing heart failure.
Not diagnosed.
So the diagnosis of heart failure will be done on echocardiogram.
Yes, that's what I asked, the gold standard.
Yeah. So that is why it is so important to get an echocardiogram done whenever you're suspecting a patient to have this thing. Okay. Next question. A 60-year-old woman with heart failure with reduced ejection fraction and EF of 32% on Ramipril, ACE inhibitor, bisoprolol, beta blocker approved for heart failure, furosemide, loop diuretic presents for a follow-up. She reports stable symptoms. Is there anything that you would want to do? Is there anything you would want to do? So yeah. So now you would like to check if the EF has improved a bit. So serial echocardiography. So follow-up of these patients of heart failure is important with the echocardiography to assess disease progression and get a treatment response. Okay. Question number 3. A 55-year-old man with heart failure at HFrEF, EF of 30, on maximum tolerated Ramipril and Carvedilol remains symptomatic and NYHA class 2. His heart rate is 82. What and BP is stable. What is the best additional therapy I can add?
Heart rate is how much? 82.
So you would want to add SGLT2. Very good. But I don't have it in the answer. So what will you add? So what are the 4 pillars? As I told you, ACE inhibitors or ARNI or whatever. Second is a beta blocker. Third is SGLT2. And last is MRA. These are the 4 pillars of heart failure management. So what is the next best drug to be added is? Spironolactone. So the answer is spironolactone. Now, the next question is 70-year-old man with NYHA class 3 heart failure, LBBB with QRS of 160 and above. I forgot to tell you, you can go for cardiac resynchronization therapy, CRT. If the patient has a left bundle branch block in the ECG,
right,
with QRS duration of more than 150. Okay. And EF of less than 30% on maximal GDMT, that is goal-directed medical therapy. So that is the indication for CRT. Here the QRS is more than 160, EF is only 28% and optimized medical therapy. So what are you going to do next? I've given you the answer.
CRT.
So this patient will need CRT, okay, to improve the symptoms and reduce mortality. Some people are so good responders, you put in the CRT today and the next morning their QRS is down to 118, 112. Even one of my professors of pharmacology, head HOD of pharmacology, he arrested. We did a CPR, we revived him, and then he remained on intra-aortic balloon pump. And unfortunately, he was a chronic smoker and chronic alcoholic. Unfortunately, his coronaries were normal. Unfortunately, because we couldn't do any intervention on the coronaries. So we actually put him on CRT. His QRS was 188, and he was recurrently going into VT. Can you imagine? It's like, how many years now? It's been 3-4 years now. It was December at that time. I think it's the 4th year on, and he continues to do so well. The next day, his QRS was down to 128 or 130, I remember. And after 3 months, it was like a totally normal QRS. Can you believe it? That is the impact of a CRT on these patients. Some of them are very good responders to CRT. Okay. Next question. A 65-year-old woman with stable HFrEF on optimal therapy. Oh, the GFR has dropped down to 45. All right, guys, I want to tell you something. So SGLT2 inhibitors, if the eGFR is above 30, you can give DAPA plus EMPA, either of them. But if the eGFR is below 30 and above 15, the only drug you can give is EMPA. If the eGFR is below 15, you cannot use SGLT2. Okay? Yeah, just a running thought. So a 65-year-old woman with HFrEF of 38% optimal therapy, GFR has dropped to 45. Potassium is 5.2. Oh my God, what should be done? It's a tough call. What will you do? The patient is on optimal therapy, means the patient is on ACE inhibitor or ARNI. वो भी potassium बढ़ाते हैं. Then aldactone, वो भी potassium बढ़ाएगा. What will you do? eGFR of 45 means CKD stage 3B. Okay, stage 3B. So the thing is that stage 3B people, the target potassium is below 6. So I will not do anything. I will recheck the electrolytes in 2 weeks. It is recommendation. It is not that I want it that way. So this patient should be rechecked in 2 weeks' time. Mild hyperkalemia 5.2 warrants close monitoring before stopping beneficial medications. Spironolactone is one pillar of GDMT, so we cannot really stop it right away. Okay. So these are very minute things that you will, fine tune yourself when you do practice. So having a potassium of 5.2 in a patient of CKD stage 3B is okay, not bad. You can give them K-bind sachet. They can have K-bind, they can have ethylene nebulization. Why? To stop spironolactone. Okay, we should not be doing away with the good medication that the patient is on. A 55-year-old man with class 3 dyspnea, EF 30% on biso, remi, and spironolactone still has persistent symptoms. BP is 110/70, heart rate is 72. What is the next best step? What is the next best step? Anyone? I'll send you a chocolate if you answer me correct. अरे चॉकलेट का वास्ता है, जवाब दे दो.
Sacubitril valsartan.
Wonderful. You get it. You get it. You text me your address, I'll send you. So this patient is on Ramipril, and one of you said ki ACE inhibitor, if I were the doctor, I would not give ACE inhibitor, I would give ARNI. So that is the typical case scenario where you will actually give ARNI. The patient continues to be breathless and the patient has HFrEF. So why to continue with Ramipril? Now my question is, can I stop Ramipril and put the patient on ARNI? Sorry. Can I do that right away? Anyone? So what I have to do is, as the recommendations go, I have to stop Ramipril wait for 36 hours, and then give ARNI. If my patient, I am fearful that the patient will decompensate, then I will stop Ramipril, put him on Valsartan, which I can do immediately. And after 36 hours, I shift to ARNI. Why? Because if you are giving ARNI to a patient who is already on ACE inhibitor, if you do that before 36 hours, the patient will land up to you with angioedema. Okay? So the guidelines are very clear. You have to stop Ramipril for 36 hours when you have to switch over. Then you add sacubitril valsartan. Is that clear? Any doubts there?
Yes.
Okay. A 70-year-old woman with heart failure and preserved ejection fraction with persistent dyspnea has controlled BP and no volume overload. Which of the following is most appropriate? So what is the drug approved in HFpEF? I told you. No. SGLT2 inhibitors. They are the only drug which is approved. I told you here, no? Yeah, I told you here, when I was here, I told you that to control BP, obesity, fluid overload, only drug approved is SGLT2 inhibitors. Okay? So whenever you have a doubt in your clinical practice also, this is the rule of thumb that in HFpEF, only SGLT2 inhibitors are approved, along with good BP control, glucose control, and obesity management. A 58-year-old man with ischemic cardiomyopathy, EF of 28%, LBBB duration of 165, on optimal management remains symptomatic. What will you do? What is the answer? So the answer is putting the patient on
CRT.
CRT. So let us say if the patient admitted to you with the heart block, CHB, same patient. Then what will you do? You will put the patient on CRT-P. But if the patient came to you, same patient with ventricular tachycardia, then what you will do is CRT-D. So these are newer devices when CRT is combined with a pacemaker and when CRT is combined with a defibrillator. CRT-P or CRT-D. The indication changes if the patient has a bradycardia due to CHB or if they have a tachycardia due to ventricular tachycardia. Is that okay? Okay, this patient needs a CRT for sure, and QRS is more than 150, LBBP and EF less than 35%. Okay. A 72-year-old woman with HFpEF, uncontrolled BP, dyspnea, BP is 160 by 90. What is the most appropriate first-line therapy? What is the most appropriate first-line therapy here? Control the BP. Which is the best drug to control the BP in a 72-year-old female?
ACE inhibitors.
So the answer will be ACE inhibitors. ACE inhibitors. A 65-year-old man with EF of only 20% despite maximal therapy and CRT presents, CRT bhi ho chuka hai iska, now presents with recurrent hospitalizations. What is the next best step?
Heart transplant.
So the only option here is heart transplant. So the only treatment here is heart transplant. Okay. So that's all for today. We finished heart failure with cardiomyopathy. I think we are not left with any topic.
Sir, arrhythmias.
Okay, so you can schedule a class for arrhythmia, and what we'll do is arrhythmia along with, then we'll do DVLA 1 hour class any day. Okay. Yeah, Sana, can we
Okay,
have
sir.
one?
Okay, sir.
Can we
Sure.
have one class on DVLA and arrhythmia management? So we will just do management. Okay, don't I cannot go into the details of how arrhythmias are generated. Will that be fine?
Yes, sir, it will be.
Yeah. So what we'll do is we'll have the ECGs of different arrhythmias, and we'll have case scenarios, and we will try to understand how to deal with them.
Okay, sir.
All right. Okay, doctors. Thank you very much for your patient listening and cooperation. Thank you. Bye.
Thank you, sir.